Yes, ma'am. So it's three, two, one. Over to you, Dr. Radhika.
Yeah. So, very good evening to everybody. Warm welcome to the FOGSI ICOG JOGI Research Methodology and Journal Club. So, the entire year we have been having this monthly event and it's been very well appreciated. So, today it is yet another forum with a lot of interesting talks. So, before we go on to the talks, I wish to thank the entire team FOGSI, ICOG, and JOGI for helping us and supporting us all the way in organizing the programs. Next slide, please. Next. So this is the program schedule for the day. So we have the experts, Dr. Sneha, Dr. Asha Jain, Dr. Nalini Anand, and Dr. Kavita Bhatti. And Dr. Sadhna is the main speaker. And other than that, we have the two presenters. And the Master of Ceremonies today is Dr. Sushma V. Dev from Mysore Medical College. Next slide, please. Dr. Charmila and myself, we are the conveners for the program, and Charmila will join shortly. Next slide, please. So Charmila is a vice president of for FOGSI 2024, and also the vice president of Trichy Obs and Gynae Society, and chairperson of the Clinical Research Committee 2016-18, ICOG member Governing Council 21-25. And other than, this slide only shows one third of her accolades. A lot of achievements she has to her credit. Next slide, please. So Dr. Sushma is Associate Professor and Unit Head at Mysore Medical College and Research Institute and Director and Chief Consultant at Aishwarya Hospital, Mysore. She is the President of SMFMI Mysore Chapter 22-25 and so many accolades and awards to her credit. Welcome to you, Dr. Sushma. Next slide, please. So we are extremely grateful and thankful to Dr. Jaydeep for supporting this program. We all know him. She is the president of FOGSI and he was the Secretary General FOGSI in 2018-21, immediate past president of MOGS, chair International Federation of Obstetrics and Gynecology, Committee of Safe Abortion. He is the Deputy Secretary of AOFOG and he has been awarded the FRCOG Honorary Causa in 2020. So these are again a few of the accolades. He is very well decorated. We know that. Next slide, please. Dr. Parul is he is the professor and head of the Obs and Gynae at Sai Institute of Medical Sciences, endoscopy surgeon and consultant, and he is the chairperson of ICOG currently and vice president of ISOPAB and numerous other positions. Next slide, please. Is Dr. Parul there? Poonam, has he joined us?
No, ma'am.
Okay. So Dr. Madhuri, she's the Secretary General FOGSI and also the Editor-in-Chief of JOGI. And she was the Joint Secretary of FOGSI 2009, Committee Member FIGO Preterm Birth, and she was the former head of the Professor and HOD at ESIC PGI MSR MG MH Mumbai. And she was a former associate professor at GMC Mumbai. Numerous accolades to her credit. Next slide, please. Dr. Sheila Mane, she's the ICOG Vice President and she's a DNB faculty at KC General Hospital, member of IMS, Bangalore Society of Obs and Gynae, FOGSI and ISOPARC. And she is the past president of Bangalore Menopause Society and so many publications and awards to her credit. Next slide, please. Dr. Sarita is the secretary of ICOG and she is the president of MOGS. She was in 21-22, joint secretary FOGSI 2017, past secretary the Indian Menopause Society Mumbai chapter and past president AMWI Mumbai branch. Next slide, please.
Yes, ma'am.
So with that, we go on to the first session. And next slide, please. Which is an aspect of the research methodology.
Radhika, ma'am.
So yes.
Sorry to interrupt you, ma'am. Madhuri Patel madam has joined.
Okay, so we can invite Dr. Madhuri. She is the editor-in-chief, like I said, of JOGI and also the Secretary General of FOGSI. Very warm welcome to you, Dr. Madhuri. And we would be very happy to hear your message for the session today.
Dr. Parul Kotada is also joining in a minute. He just
Yeah. So if Dr. Madhuri can, so if
Can
you can
you hear
stop
me?
sharing the slide, please stop sharing the slide and let us
Okay.
have Dr.
Okay, 1 minute. Huh? They are asking me something. No?
We can hear you very clearly.
Hello.
Dr. Madhuri, we can hear you loud and
we
clear.
can hear you nicely. We can
Now
see
we can
you
see you
also,
all.
madam.
I can log in.
Welcome.
अब आप
Can you
देख
hear
लीजिए.
me now?
We
Yes,
can
yes.
hear it. Please carry on.
Can you hear me?
We can hear you and see you also, madam. Carry on.
Hello.
Yeah, Parul sir. Welcome, sir.
Can you
Good
hear me
evening.
now?
Well,
Yeah,
thank
we
Yes,
you.
ma'am, we can hear you. You are very much audible. Good evening, sir.
Okay,
Good evening, ma'am.
thank you. Thank you.
Good evening.
Good evening.
So we welcome Dr. Madhuri to speak a few words, followed by Dr. Parul, please, and then we will start the session.
Okay.
I think Madhuri Patel, she has some network issues.
Can you hear us, Dr. Madhuri?
Yeah, I have network.
Yeah, so
No,
I think
I
Parul sir
suggest that
can
you switch off the
take
video.
over first.
I suggest that you switch off the video, then when you speak, we can hear you better.
I will switch off the video. I'll switch off the video. Okay.
Yeah.
Now it's okay.
Yeah, now we can hear you, so you can, you can give a message.
Acha, can I share my screen or something now only?
I don't know whether they made you a co-host. You would like to present something?
You said no something. Today is my talk. No something you said.
Madam, today's talk, it was supposed to be you, but then since you said it was your inability to do so, we have invited Dr. Sadhna.
Oh, I thought I was just trying my best to come. I'm in the very, I'm in MP. I'm in MP. Okay. Then I will just say hello to everybody. Okay.
Then you also said you will share a recorded message. I kept waiting for your recorded message. Nothing came. So then we invited Dr. Sadhna and she has very graciously accepted.
Okay, fine. No problem.
Yeah.
No problem. No problem. Okay.
That's nice. So I'll get in touch with you back again, Dr. Madhuri. But would you like to
No problem. No problem.
Would you like to say a few words for the session, please?
Yes. Respected our Jaideep Tank sir, Dr. Parul Kotra.
There is a huge connectivity problem.
Yeah, I think we can.
Very good initiative. FOGSI Society every year, and then we have 4 in FOGSI and 1 in ICOG. And we have started these programs in 2004. Now 20 years are over for our PICSEP program, and this is an initiative Dr. Parul Bhai has taken, very well, and this is appreciated by many of our members. And therefore, I'm really happy that now we are into research methodology. We are getting more and more papers with such initiative. And Radhika knows that, how difficult to refuse each paper, because in a journal, we get 1,200 papers per, year, and we have to select only 110, original papers. So it becomes very, very difficult to select. But with all these programs, research methodology has really taken a good, shape, and we are getting good, authors to submit their paper. And therefore, I'm really happy, and I wish all of you the best luck.
Thank you so very much, madam. So, Dr. Parul, would you like to also address the audience?
If it is a choice, I would avoid that. Since you asked, would you like to? No, it is just a repetition. That is why. See, okay. I do appreciate all your efforts, the entire team. And this is obviously a very important program for trainees as well as the faculty in medical colleges who would learn a few tips that how to publish something, what are the nitty-gritty of any paper, how to evaluate a paper and all those things. And I'm sure that this program will be very useful. Please get on with it. I am a little bit tied up with the ICOG annual conference, which is coming up after 10 days. And I would also take this opportunity to welcome you all to make a visit to Ahmedabad and participate in that. Thank you very much for asking me to be here.
Thank
Thank
you.
you. Thank
Thank
you
you for
very
the
much.
invitation as well.
Yeah.
Thank
Very warm welcome to Dr. Sadhna. So we all know her. So can we have the first slide, please, the introduction? So before the slides come out, I can personally vouch for her very simple and friendly and forthcoming attitude. Dr. Sadhna, we all know. She has affiliations to numerous professional bodies and innumerable number of individual awards and honors. The latest being APJ Abdul Kalam Life Achievement Award in 2023, Economic Award 2021, and MS Signature Award 23. Huge number of academic publications and awards, organizing chair and secretary of conference of numerous number of conferences, and orations have also been awarded to her credit. Dr. June Thapa oration at Nepal Society, Dr. Urmila Gupta oration, and so on and so forth. So the entire, we all know you very well, madam, and the entire slide is filled with your accolades, and we know that you really deserve it. Warm welcome to you. It's an honor to have you as a speaker today.
Thank you, Radhika, and my regards to Dr. Parul Kottawala, Dr. Madhuri Patel, Dr. Jaideep Tank, Dr. Sheila, and Dr. Sarita, and thank you, Radhika. Just knew that I just replaced Madhuri by chance, so it's okay. And please stop slide share so that I can start my slide share. Please stop slide share. And Nilima, who is there? Yes. So I will be talking as Radhika suggested me few topics, and I said that I will be speaking on evidence-based medicine and clinical research as well as clinical practice. So in Radhika, I really agreed for this, and I will put on that how evidence-based medicine evaluated, how it came into thought process. And now the things are really having a lot of repercussion from the medical fraternity. And we hope and believe that at ICOG, we will look into every part of it and how these modalities can be best utilized, not only by the researcher, but by the clinical practitioner as well. So, a big thank you to all fellows and members of ICOG to having me elected as a ICOG Vice Chair elect and in the ICOG. And I hope that I will be up to your expectation, what belief you have kept in me. So truth is a pathless land, and what Krishnamurti says that teachers and disciple actually search together to search what is truth of today and perhaps tomorrow. So truth has something we have to reach over there by the different ways. We work in dark, we do what we can, we give what we have. Our doubt is our passion is our task, and the rest is badness of art. So these beautiful mystic words says a lot about the medical practice, which remains the science of uncertainty and an art of probability. Can evidence-based medicine make it very certain? Let's see and let's explore. So what is the concept of evidence-based medicine? How it came into the thought process that they thought was to integrate the best research evidence with clinical expertise and patient values. So the three arm we have to always remember, it is not only the research and evidence, it is the amalgamation of evidence with the clinical experience as well as the patient values. the practice, if we want to evolve in EBM, it involves a process of lifelong self-directed learning in which the caring for the patient creates the need for important information about clinical or the other health issue. So in evidence-based medicine, when we are practicing like in life or for the patient care, it is a constant de-learning and the relearning. The thought has been traced to 11th century, where evolution of the efficacy of medical intervention is cited in Avicenna canon of medicine. Slowly, the thought process got on the evolving, and the Professor Cochrane, what we read daily, the Cochrane Review, who was a renowned Scottish epidemiologist. There was a McMaster University, a research team led by David Sackett and Gordon Goyette, who improvised tactics to verify best evidence. So it is best or not. It is only in 1990, right from 11th century to 1990, that evidence-based medicine was used by David Eddy. And from 1992, the evidence-based medicine, that is EBM, showed its first appearance in the medical literature. Ever since, a growing number of international publications have been released in domain of EBM around the globe. So this has been the history and the thought process, and it bridges the clinical research and the clinical practice, and it is a fundamental shift in healthcare, which emphasizes that we should integrate all the three values. What is the aim for it? It is not for our glamour. It is not for our showcase. The aim is that the patient receive most effective personalized care based on scientific evidence. So this is the aim, which has been very, very noble. We want to have a very good quality of care through identification and promotion of care, and what is good for the patient and what is not good for the patient, so that we eliminate that practices from our clinical practice. Simple example in obstetrics are that the liberal episiotomy versus the restricted episiotomy. We should avoid anemia and the starvation in labor management, and the universal active management of third stage of labor, which has been practiced by the evidence-based medicine throughout the clinician of all over the world. So this is very important that as a healthcare professional, we develop key evidence-based medicine skill, and for what we have to have the time as well as the ability. We have to find the best evidence. It is not only find the best evidence, we have to have that attitude for critically appraisal of those evidence. We incorporate different sound scientific evidence, which may be inconsistent, sometimes contrary, and then we apply in patient care and management. So it is not that as simple that going through the paper and following it, putting into the practice. So this is always not a that easy task. You have to learn, like we see, we learn the surgical skill, or we learn anything about using ultrasound. The EBM also the tool, we need to know the tool, and we need to know how we have to apply these tools to our clinical practice. So it allows the integration of all the things, good quality evidence, what is the clinical expertise, your experience and value of the patient, and what is the best method that we can treat this situation. The other factors such as personal experience, your last experience, judgment, skill, patient values, and preference must be considered. So it is not something fragmented. It is not something dictatorial. It is total and complete if we want to have the fulfill the aims of the evidence-based medicine for which it has been evolved. So what is the STEP model for all the younger fellows and even the seniors? We want to know how we can apply into the clinical practice. So first is the formulating answerable good question, then finding evidence, appraise evidence, apply evidence, and then evaluate the performance. Yes, it is also the thing that what you have learned and what you have done, it was helpful or not, it was beneficial or not. So this is the 5 arm of the evidence-based clinical practice. I will come to clinical research as well, evidence research, but in clinical practice, these are the 5 arms. So when we come across a particular case problem, we are confused, we don't know. So asking the right question and understanding our own question is one of the very complex tasks of the human brain. So we have to have a very well formulated, clear question which should be directly focused on problem at hand, answerable by searching medical literature, and what you quest and how you question is the reflection of your wisdom. So more you mature, more clear are you what you want to ask actually. So the PICO is the mnemonic which we say for the framing the clear question. So P is for patient problem. I is the intervention, that is test or exposure of interest. C is the comparison intervention, and O is the outcome. Like we want to see that steroid in idiopathic thrombocytopenic purpura in 30 thrombocytopenia in 30-year primary gravida, we want to have the steroid intervention or not. So the patient problem 30-year, 32-week gestation, low platelet count. Intervention corticosteroid. Comparison no steroid. Outcome whether the platelet count increase or the gestational age at the safety level has crossed. So that is the idiopathic thrombocytopenic purpura in third trimester. Does the administration of steroid improve platelet count and improve obstetrical outcome? So asking and framing right question is the first step. And that has to consider what is the patient population and what is intervention, what is comparison, and what is output. So this is 4-point PICO or PICO, you can say. And you must frame, you must test your question in that mnemonic, and that will help you making the clear question. The search term. Now, after this, you are searching what the evidence says. So you have to search for the evidence, finding evidence that what are the identified primary evidence, what are the secondary sources, and what is the search for the primary sources. So it is the finding the good research paper and the good quality research paper searching is an art. And many people, we have a lot of experts, including Dr. Radhika, Kavita, Asha, who are really into the research, and we will like to have their inputs as well. So the traditional sources are textbook and journals. Asking colleague, we ask from our seniors, we ask from the person who is more experienced. Then secondary sources are the quick answer to specific clinical question, where the young generation is very accustomed, and they easily go to the best clinical evidence arguments on the Google. I will say that nowadays I see the tendency that the students, and I get this feedback from the teachers, that the postgraduate today, they argue with us because they say this is the latest evidence, and they want to ignore or demean the traditional and classical teaching, which is from teachers, which is from textbook. So this is something to be very carefully looked on. And I think we at ICOG together will see that the latest evidence is actually based on the classical teaching, classical principle of medicine, which we will see in the later part of our presentation, that how the world doctors are responding to the enigma of the evidence-based medicine. So how we search, it is an online electronic beside primary and secondary source, and how we search it, it is the ability to search this database is an important part of the evidence-based medicine, and we have to have the effective search. But does the latest evidence, very good papers are accessible to it? It is a big question mark, especially in a country like India and the South Asia. This hospital can have good internet facilities, but many publications are chargeable. They are not getting revealed to this, and the people don't have that money to spend into those articles. And how we search, so a lot of generation, mid-level generation, senior generation doctors are not that comfortable in searching it. So this is something, a very practical issue which we have to search, and which limits the utility of evidence-based medicine. Then after searching, it is like amalgamation. A lot of research papers are there, but what are the good quality, what are not good quality? It is also need a critical appraisal. So Cochrane library database, Medline, PubMed, these are few things which we frequently search into our question or framing our research, and it needs a little bit computer knowledge as well as the skill and to reach the good papers. So this is the Cochrane database. These are the few sites which we can access for our question, our clinical question, and we must be aware of it. And I think we can, an ICOG with all the expert and office bearer, we can put certain something linked to that so that any ICOG fellow and member can access easily to these sites to reach the good evidence level for their questions. So one question keyword and database is finalized, then we go for the search, and you can do the final search like and or on. So few papers who have both the term like steroid and the ITP, and few have the one part, and then you can make a little bit fine tuning for the search in the evidence-based medicine. So you receive suddenly too many articles. So how you say, then you can further find search and or then the RCT or review article, date of publication or study population. So in respect to your clinical query, you can shortlist the thing that like you shop many things and you finally choose 4 or 5 things so that you can reach the right evidence for the critical appraisal. Now, the critical appraisal of the research paper is not an easy task. With all my experience as a corresponding national editor of various journals, requires a lot of time. It requires a lot of insight into how the research is made. It is good forward or it is a less forward. What is research methodology? And it again requires a lot of effort, and it is a lifelong effort. We have several tools for appraising research article like CAS and the CAS tool. And this is again, you have to learn, and it is something we have to learn in the current scenario if we want to have the real benefit of evidence-based medicine. So this is we know, like in all ICOG journal, what is the level of studies. It is hierarchy from the first well-conducted RCT to expert opinion. So it is a grading of recommendation, which we come to know, which we have to know that what makes the strong recommendation, which we should apply, and what makes the weak recommendation. But RCT is something, it is fashionable to say, we always argue and we are always like something showcasing that it is RCT, but it is something that what say our colleague that you should randomize till it hurts. So RCT doing is not a very easy task. It requires a lot of money, sometimes sponsors, economic support, and everything is coming. The fourth is the applying the evidence. So the paper says that recommend factor 7 is a very good life-saving measure in PPH and DIC. But the ground reality that RA factor 8 is not available with us. The patient cannot afford this compound. So actually, it does not actually turn up into the practice because it is not available, or it is not in the considering with the patient desire and patient's circumstances. So this is something very important which we need to consider, that where we are practicing and the person who we are treating, whom they are. So that remains again the basic of medicine. And again, the evaluation, yes, you did, you use the steroid, you use the RA factor 7, but it was beneficial or not. So say boldly, it is not so that some paper says that it is effective, it is actually effective. You audit what the performance, what you have applied in your clinical practice, and your experience will make the tomorrow's evidence. So life is something in a stream. We have to start with the clinical question and we return to clinical question to see how the process works. So it needs continuous re-evaluation, and it is by us, by clinician, and it is not like a stationary sort of thing. It is a life document, which is a perpetual wheel of improvement rather than a one-time linear process. And we have to be very, very careful about it. So the evidence-based medicine all over the world, it has been followed from China to Western world to Indian country. And many professional bodies say that we should apply the evidence medicine in our clinical practice. We have advantage. What are the advantage? Clinician update, knowledge base, improved understanding of research method. You have to learn the research method. Physician become more critical in analysis of data. They have increased confidence, increased computer literacy. data search technology, and better reading habit. So if you apply these methods all EBM, you will be a better and a more confident and more learned person. But the challenges are not the less. You must have the time for all these learning, and at some point of time we really become a little bit like deafened. We become a little scary to learn a very high computer skill. Information overload, this is actually killing us. Require financial resource and the infrastructure cost, subscription cost to unavailable journal. And finally, if you find sometime the evidence is not suitable, affordable, desirable for the patient. So this is something for many things in obstetric, like genetic screening, NIPT after 35. Patient want it or not want it, this is something, it is very, very important. So a few things I will take from clinical practice to evidence-based medicine to evidence-based clinical research. And again, the question start from the right, ask the right question. So a lot of wastage on the research is being done all over the world, which has been already proven. So Lancet have introduced, and many journals have introduced, that when you frame new research, first explore what was the evidence before study, what is added value of this study, and what are the implication of all available evidence. So this is the time to all researchers that you should ask your question on this criteria, and then you will add value to your new study. And the second thing is you have to say a good justification for using. So again, it is the searching all evidence and critically appraise all evidence, so that you know what question you want to make in this research paper, in your new research work, so that it add value to the clinical research and the practice. So this is the challenges that many clinician researchers, despite being aware of systemic review, they have lacked knowledge, skill, and time to conduct one. And there is no incentive to do this systemic review, which is very hard tasking. And research institution, funding agencies, ethical committee, and publisher need to adapt and remove barriers to implementation of evidence-based research approach. So the ICOG and the journal can do a real lot thing in this a huge gap. And how to use this evidence-based research and how to make conclusion. So all the young people, it is not conclusion of your study. It is the conclusion of your study combined with what the other research paper says. And that should be the mix of this, and the interpretation of reposting of result from new study should be always within the context of what is already known. So a lot of research waste is being done. A lot of patients are subjected to unnecessary drug or intervention, and evidence-based research can make a real breakthrough, so that we utilize our resources to the best research which can add value to the patient care. A lot of controversies are also, and in the last part, I will really put what controversies and what debates are coming against this evidence-based medicine, but we can take the good one and we can find a solution for the best use of the evidence-based medicine. So if you rely on evidence-based medicine, it is always the equally satisfying evidence practice. Sometimes it is not, because it is not a panacea. So these are few good paper which I will not go into detail, but I will go into some tracks that a lot of the important members on the editorial board of the reputed papers say that the quality of clinical research is very low, and 30% of paper can later turn out to be mistaken or overstated. So these are few, and we are making the clinical practice, and our clinicians are being guided by these all research evidence. So the quality of research paper is something which is questionable, and especially the economic support, and like the industry is pushing certain drugs and they are getting overstatement, and we as a doctor have to be very careful about it. It is again the thing that the very editorial board say that the many of the clinical research is poorly designed, conducted, analyzed, and reported, and we have to find the system about it. So read with a caution that it. And the second thing is, yes, EBM says give this drug, but it does not usually say why and how it is done. And again, it emphasizes that our basic classical teaching, not only of the subject like OB-GYN, of anatomy, physiology, pharmacology, should be very strong, and it should be the multidisciplinary perception of the clinical research paper. It is not only the clinical intervention, it is the pharmacological, how it is happening, why it is happening, and what is the hypothesis. So these are few gaps in the evidence-based medicine, which we have to say it is a art, science, and commerce. Creating evidence has become commerce. In my very deep journey into the professional bodies, I see and feel very, very strongly that it has been promoted by the industries. And when they spend billions of dollars, they say the overstatement. Underprivileged population is ignored because they are not being taken into the creating the research evidence. And the public, the people, when the general practitioner are having a little bit loss of faith, we have to look into this. Sometimes the trials take a long time into the coming into the result, and by the time trial result come, many things have been passed, many water has been flown through the river, and this is again an important gap which is in the evidence-based medicine. Like we have women trial and promise trial and progesterone, and actually it is not giving any clear answer to it, but we see that how excessively the clinician are using progesterone, which is so much abused and the overused drug. So evidence medicine to evidence-based practice. Another thing I want to say that it is on our mindset. So that breech trial says that, yes, the doing cesarean in breech is safe. So we all accepted always 100% cesarean for breech, but the PPRM trial says that in the twin study, you can go for trial of labor, but the people don't accept to it. The practices are the contrary. Everyone want to do the cesarean. So it is an interplay of many things. It is patient very high expectation from practitioner, foolproof outcome, and we have to be very sympathetic, and we have to take consideration of all these issues. So what are the three fundamental tension on which medicine find itself? What is known, what is unknown, what is universal, what is particular, what is body, and what is self? So self is something which is intuitive in doctor as well as in the patient, reaction to that disease or that problem. Evidence-based medicine reflect in all the three circles, but we have to have that a perception of it, that how it is fitting into our clinical circumstances and the patient values. So it is not dearth of desire, but it is a dearth of methods that EBM has yet to achieve attention in all the three circles. And with narrative medicine method, it can be really true to all promises. So we can have a lot of things. A renaissance in EBM is the dire need of today, because now evidence is being really created by a lot of financial pressure, a lot of publication bias. We don't get publication of our country and region in the JAMA or in the MATPAB. We always see the outside like Western world articles, and it is real thing that we are having maximum still, but the 94% of literature is from Western world. We are having maximum preterm love, but the 80% of literature is from the Western world. And so where we are, our clinician, from where we get the direction, how do we manage our patient in our circumstances? And this is something we have to look into. The COVID has said, the COVID emergency, too much emotion, and too little evidence. And the clinician came out with their own intuitive care, and how the critical care situation how the physician take the decision, and that intuitive care and the clinical expertise has to be taken into the consideration of evidence-based medicine. So, Carlo, these are few interesting paper. I will say you really read them, because we have to have a argumentative mind. We have to have the critical mind. Only then we can become a good researcher. So Carlo emphasized danger of polarized debate, somewhat favor for EBM and some are against the evidence medicine. Actually, it is not so. We have to have our intuition expertise. We have to have others what people are doing, and we have to see the patient and our clinical circumstances. Future will be very different. and the world is changing at high speed. And tomorrow, these research papers, these RCT will be changed from the big data, which will compounded by the 3 V's: volume, velocity, and variety. A subset of big data will be the real world data, that is data from health record, hospital record, registry, health insurance data. It may be from our and your Facebook data. So how we are having Facebook, WhatsApp, everything free? Because somebody is extracting our data to see what is happening. So that tomorrow and the future of evidence medicine, evidence-based medicine will be entirely different. And next generation of EBM will already, it has been actually the process have started. Everyone has got the smartwatch. They measure their own blood pressure, sugar, all oxygen saturation, fat, and the protein balance, everything. And that tomorrow will be a different armamentarium for the evidence-based medicine. And because the COVID epidemic actually exposed an inherent limitation of clinical practice landscape and also gave the positive view. So the evidence-based medicine help providing evidence, but not all evidence. All clinicians really need in a good balance between available evidence drawn from the good quality research work and emanating from the lifelong experience, sound clinical judgment, and the personal inferences. So important thing that what the teachers are feeling, that this evidence, which can be supported by so many things, is snatching the confidence of average clinician. Oh, you are not doing this. You are not giving flu vaccine. Oh, you are not doing this thing. Don't take that confidence from a clinician who has spent their life in the patient care. Their experience is valued. The relative weight of each component, that is evidence, your experience, and patient profile, patient desire, is left to vigilant physician to decide. It can be an essential tool to improve quality of care with the integration of all the 3 elements. Thank you very much for this opportunity. I send my regards to my all experts, Sneha, Aisha, Nalini, and Dr. Kavita. And I look forward to really something like listening and learning from our experts. Thank you very much.
Thank you very much, madam, for the beautiful presentation. So I would say it is a complete package. The goods, the bads, the entire debate, everything into one. So I think the audience has got a good glimpse of what is happening. So our experts are there. Dr. Vidya, Dr. Sneha, Dr. Kavita, Dr. Nalini, would you like to share your thoughts on this?
Hello.
Yeah, we can hear you.
Am I audible? Yeah.
Yes.
Sorry, I had to join through this mobile because I'm in the hospital working.
No problem.
So
Yogita, please don't share the slides now. We are just having a discussion. Yeah.
Okay, ma'am.
Thank you.
Throughout the working, I was, almost glued to the presentation, Sadhna madam. It was covering the entire clinical aspect as well as the research, how you have to link your experience with the evidence. You have taken us through the entire, I would say, spectrum. And that was a very, very wonderful presentation. In fact, I would say every one of us should have this presentation and should go through. That is what I will say. And I would request you to share this presentation also. I think majority will learn a lot of research from this. Thank you so much.
Thank you. So thank you very much. If anybody else has a comment to add, or I think I would like to also comment on this, Dr. Sadhna. So starting from, I just can't help it. Sorry.
Yes, I am actually eager to listen to you.
So evidence-based medicine, actually, you are very right. It is not something fashionable, it is something scientific, and it has to be critically analyzed before we acquire. So there were 2 or 3 things that you had highlighted. So for instance, whether the quality of the quantity as well as the quality of research papers which are coming out from the countries which are having the biggest burden of the problem. For instance, you highlighted about the stillbirths, the preterm births. So that is an eye-opener for us. In fact, we had also, published a paper on, people are also now coming out with evidence-based guidelines in India. And for example, FOGSI also talks about recommendations. So there is a system in which, there is a globally accepted standards and methodology by which the guidelines are developed. So it's like you get good vegetables, you make a good curry. If you don't have good studies, the guidelines, the outcomes, the evidence will be equally affected. So that is the starting point for us. I think it is important for us to undertake good clinical research and publish it. So by the time we write the protocol and by the time we are through the research, I think we find it difficult to publish. Especially what you highlighted, JAMA, the Lancet, these are for us like a dream. So I think, but now there is a lot of option open now. There are various databases as well as the publishers who are encouraging. In fact, there are calls for proposals and calls for research articles every month which are coming out from various publishers' side. I would encourage everybody to see at least the major ones, Elsevier, for instance, similarly Wiley. So these people, they have calls. So that gives us an opportunity to publish. And mind you, if the quality of research is not good, it will not be accepted by those journals. So that is an indication for us to improve our own thing. Number 3 is whether can we translate those evidences to our country straight away? I totally agree with you. The answer many times would be no. The reason is we do not have the wherewithals or the so resources to copycat whatever is being told in the Western world. They have developed it for their country. So there is a process of adoption. It is also called as adoption. So it's a process, adoption or adoption. So there is a process of deriving that evidence-based guideline, developing your own guideline which is suitable for your context, for your country. And in that process, you also aggregate what is available for your country. And even if the quality of the research papers is not good, today there is a method of developing, extracting the evidence from those. And like you said, individual patient data. So when you have a collation of so many samples, it may not be fitting, it may not be a right shoe fit for your PICO. For instance, if there is a patient 20-year-old with abnormal uterine bleeding who has no children, what is the treatment? You may not have an evidence for that at all, right? So you need to have, eyes open for that sort of a thing. You should, you very nicely highlighted how important it is for us to have a knowledge of the literature search. And today we have the entire thing open for us to go through the computer just by the click of a mouse or a key. So I think it opened a lot of vistas for us to talk about and discuss. So thank you so very much. I truly appreciate your talk and also the words of wisdom. Thank you very much. So now I hand over the proceedings to Dr. Sushma, who is also the Master of Ceremonies for today's program. And she's going to be taking us through the next aspect of this session, and that is on the journal presentations and a part of the Journal on Obs and Gynae of India, Journal of Obs and Gynae of India. Thank you. Over to you, Sushma.
Yeah, ma'am. Thank you, ma'am. It's indeed a great learning from listening to Sadhana, ma'am. She opened a wide spectrum of how we should approach the research methodology, everything. The thing in India is we need to have a uniform protocol because being the vast country and vast population and vast clinicians, we have a varied diversity in the clinical practice. But through ICOG and FOGSI, we should have a honest and a very important dedicated efforts to make a uniform protocol for our populations. I think FOGSI and ICOG and JOGI are doing excellent work in this regard, so that all the clinicians and all the experts can come in the single platform so as to propose with all our societies one of the best protocols for our Indian scenario. Right. And indeed, it's my pleasure to start.
I just wanted to add one point, which I thought Dr. Sadhana had a very valid point in saying that don't look down on the age-old experience of your teachers. So very important. You don't need evidence to say parachute saves your life. You see, you don't need a clinical research or an RCT with parachute and without a parachute. It's like that. So there are a few things which are so peculiar to our country. So I think it's words of wisdom. Our Gurukul Parampara should also continue. It is the amalgamation of the two that's very important. Thank you.
And today we'll move on to our journal discussions. We have very important clinical perspective and important journal being discussed on the obstetric perspective. I invite our first speaker, Dr. Shilpa N. Vijay. Poonam, can we have our CV, please? Before that, I would like to invite our experts. We have our Dr. Sneha Boya ma'am. Everyone knows. Madam is an expert and she's been the part of earlier discussion as well. Dr. Asha Jain, Dr. Nalini Anand, and Dr. Kavita Bhatti. Do we have our experts logged in?
Yeah, they're already there, Asha,
Yeah.
Sushma, and we have also introduced them.
Yeah,
so we can proceed to the session now.
All right, ma'am. So over to the first journal by Dr. Shilpa N. Vijay, who is a senior resident in the Department of Obstetrics Gynecology, Mysore Medical College and Research Institute. She'll be discussing the journal from American Journal, Maternal Fetal Medicine 2020 publications. The article title is Antenatal Corticosteroids in the Late Preterm Period for Growth-Restricted Pregnancies. I'm sure we'll have a great discussions on the, more importantly, on the journal perspective and how the evidence-based information is brought about and how the journal is being studied. Over to Dr. Shilpa.
Thank you, ma'am. Is my screen visible, ma'am?
Yeah.
A very good evening to all the seniors and my friends over here. Today, I'm going to present a journal on antenatal corticosteroids in the late preterm period for growth-restricted pregnancies. FGR defined as estimated fetal weight less than 10th percentile for a given gestational age. A very common complication of pregnancy associated with adverse perinatal outcomes, and it's definitely a very frequent indication for delivery in the late preterm period. And in 2016, the antenatal preterm steroid study, ALPS, this reported that antenatal corticosteroids administered in the late preterm period, that is between 34 to 36 weeks, 6 days gestation, reduced the rate of neonatal respiratory complications at birth. The utility of this intervention in women with FGR, fetal growth restrictions, still remains unclear. So the aim of, because that group was not studied in particular, so the aim of the study of this particular article is to determine whether administration of antenatal corticosteroids in the late preterm period in pregnancies with growth restriction, whether it decreased the need for the respiratory support at delivery and other neonatal morbidities. So the methods and materials here was, the study design was single center retrospective cohort study. And the inclusion criteria, more than 18 years of aged women, singleton pregnancy, growth restriction pregnancy, who delivered between 34 weeks to 36 weeks, 6 days of gestational age, regardless of the indication of delivery. Exclusion criteria was the pregnant women if they had any
Dr. Sushma's connection is broken. Dr. Shilpa's connection is broken, Dr. Sushma.
I'll just check with her. Dr. Shilpa?
Or HFNC, high flow nasal cannula, for 2 hours or more within the first 72 hours of life. Oxygen requirement with FiO2 more than 30% for 4 hours or more. Mechanical ventilation at any time after birth, and stillbirth or neonatal death. So these were the outcomes that was considered in this study. And the primary outcome was compared between steroid-naive pregnancies, those who had not been given steroid, and the pregnancies who were exposed to betamethasone in the late preterm period. That is between 34 weeks to 36 weeks, 6 days gestation. Univariable and multivariable statistical analysis was performed, and p-value of less than 0.05 was considered statistically significant. So in this study, in the particular institute called the Christian Hospital, 247 women met all the inclusion criteria. And among them, 136 had already received corticosteroids, and 111 did not receive corticosteroids. And the results showed that the demographics like the pregnancy, the age, the parity, everything could be matched. They were similar between the groups, with the exception of those who received betamethasone being more likely to be nulliparous, and also they were more likely to be associated with preeclampsia. The primary outcome did not differ between the two groups. It was somewhere around 16.2% versus 12.5%. Multivariable modeling controlling for parity and preeclampsia indicated that the rate of the primary composite respiratory outcome, it was similar between the exposure groups. Adjusted odds ratio 0.63. And this was the table. This is the table that depicts the same. The p-value being less than 0.0, more than 0.05. And the conclusion was administration of antenatal betamethasone in the late preterm period for growth restricted or small for gestational age pregnancies delivering in the late preterm period did not significantly decrease the rate of respiratory complications in the newborns included in the study. So there was no change in the neonatal morbidity. Additional research is required to determine whether this intervention is beneficial to this high-risk population. And the scope for the future studies, according to this article, it says that the post-hoc study, HOC study, it suggests that the minimal sample size of 2,200 was required for statistically relevant results, wherein we barely had 247 over here. And that is why there is a type 2 error that is seen in this study. So there is more of false negative that can be seen. So to avoid this, definitely the sample size has to be increased, and the subgroup analysis is also required. That is optimally timed steroids. That is the delivery is happening 24 hours after steroid administration and before 7 days, within the 7 days of administration. So this is called as optimally timed steroids versus suboptimally timed steroids. All were mixed in this particular article as it was a cohort study, retrospective cohort study. So that can be done for further results, and subgroups of FGR with abnormal umbilical or Doppler or other forms of any abnormalities, maybe in just the FGR in preeclampsia. So these kinds of subgroups can be done, and further studies, if we do in future, maybe we will be getting better significant results statistically, so that we can imply. The ACOG has already recommends ACS, that is antenatal corticosteroids injection, between 34 to 36.6 weeks of gestation. However, this small study didn't give much of an importance regarding that. So further studies in this direction will help us to know the statistically significant results, so that any new recommendation can be implemented. Thank you. Thank you.
Can we have the expert opinion on this?
So I'm Dr. Kavita. Hello, can you hear me?
Yes, ma'am. We can hear you.
Okay, so as pointed out by the study it had already been proven that in 2016, the antenatal late preterm steroid study, which concluded that there was a reduced rate of composite neonatal respiratory complications in those who received antenatal steroids. So, what is your take on the ethical aspect of this study? If it has already been proven that late preterms benefit, and because here they have divided into two groups, one which received betamethasone and one which did not.
Ma'am, this is
Is it ethical to divide groups into this, knowing that it is already proven to be beneficial?
Ma'am, here it is a retrospective study.
And okay. And this retrospective study was done, I think, from which year to which year?
Shilpa, you can show the slides if you have them ready with you.
Yes, ma'am.
I think that's a very important question. In fact,
yes, ma'am. Yes, ma'am. It was done in the year 2019.
19.
Yes, ma'am.
So in spite
Actually,
of
it was from 2015 to 19. Okay, it was not just 1 year. They gave the results in 2019.
So I'm just wondering what happened after 2016 when the trial came out to be beneficial and how ethical it was. So,
ma'am, if it's retrospective, that doesn't apply, I think, because they already have data. They are not changing anything.
Yeah, but after 2016, when it was published, then they should have, I think, changed their protocols of giving late preterm births the betamethasone.
Yes, ma'am.
So
They should
that
have
period
implemented.
between 2016 to 2019 is a little vague.
Can I add a comment, interesting comment to this? In fact, Dr. Kavita, I agree with you. In the utility of antenatal steroids was well proven beyond any doubt by 1976. You know, if you were to look at the evidence, the forest plot of the RCTs that were undertaken to prove conclusively the utility of steroids. This was there in 1976. However, it was translated to practice in somewhere around 1999, 2000. You know, it really became very popular.
Yeah.
You are absolutely right. Lot of these evidences are not recognized, number one, and there is a duplication of study. But in this case, the authors have done a retrospective study and probably added more value to the existing evidence for whatever it's the benefit. Retrospective studies, as it is, do not have great weightage.
Yeah, I
in terms
understand
of
that,
evidence.
but I was just wondering when the study came out in 2016-17.
Exactly.
Why the protocol?
Why the institution they had an arm which did not receive steroid when there was ample evidence to do so, and even if it was retrospective, it was 2015 to 2019. So even if you give the allowance of 1 year, what happened to the next 3 years? I think that's a very, very valid point. Shilpa, you can write a letter to the editors.
Moreover,
you can do that.
And probably we cannot do further randomized studies giving the injection and not giving the injection, and it has already happened, so indirectly it gives us some.
No, that's okay, but I think it's an important point. You can certainly consider, you know, if the total duration of years that you are talking about is actually the fact is really true, then you have a valid point. I think Dr. Kavita.
We have actually, as per the WHO and Indian Maternal Ministry of Health and Family Welfare, the recommendation of steroid as per the WHO globally is up to 34 weeks. Beyond 34 weeks is not mandated to give a steroid.
Correct.
So, but in a Western world, they even approve the corticosteroid up to 39 weeks of pregnancy for elective.
Yeah.
So this raises the controversy of making the uniformity. That is one of my query. Another thing is there a relevance having a duplicate studies like this? So already one evidence is there, a lot of evidence, global evidence that corticosteroid is very much beneficial. So we come across many researchers and doing it in a small sample size and coming for publication like this. So, and that too, it was a good journal of AJOG. So how sensible and how ethical are there in, first of all, to kind of do these duplication studies and to be accepted by a major journal?
Yeah, there are different guidelines saying different things, like ACOG recommends giving antenatal steroids between 34 and 36 weeks. But if you see the updated RCOG, what they have written is that up to 38, 39 weeks, but only those who have planned cesarean section.
Yes, yes.
Yeah. And then WHO also has put the guidelines in 2022 where they say corticosteroids is not recommended when you are undergoing planned cesarean section between 34 to 37 weeks. But then for the other things, it is the same as the previous guidelines that between 24 to 34 weeks, you have to give 34 to 36 weeks if not given previously. And you can also consider giving steroids, especially in patients who have not delivered within 7 days, that is known as the rescue steroid. So you can give it within 7 to 14 days if not given previously before 36 weeks. So the different guidelines are there. And
excuse me,
yeah.
Myself, Dr. Nalini Anand. I'm sorry for the, voice reason. I just want to add one thing that we are forgetting the limitation of the study. It's just 247 cases, and that too at one single center and retrospective. So, looking into those facts, maybe like what was the question that why it wasn't implemented, maybe that's the reason for that.
No, but Sushma, in answer to your question, whether this was how this got published at all in a good quality journal,
Yes, yes.
Yeah, that's his point.
Even
of
I have
concern,
that.
because when we have submitted very, very extremely knowledgeable articles, and we tend to not get acceptance. But this article was literally not in any ethical format, was not proper. That's the wonder of acceptance in the Western literature.
No, we all of us have experienced that. We do think there is a bias. However, those editors, they say that there is no bias. In fact, we encourage presentations from LMICs. However, I would still want to say that we need to again have a relook at this thing. Unfortunately, I missed a few slides in the initial part. So, but I think we need to have a relook. And if this is really the case, it is worth a letter to the editor. That is how it improves the scientific interactions and the fact that we are also aware of these
probably the
fallacies that are
authors and
happening.
editors will have an answer to our questions.
Exactly.
So
We need to do that. It's not anything. So when there is a critical appraisal, it is not a criticism. It is valued in the scientific world of the time that you have spent to actually critically appraise that literature. It's like a reviewer. So somebody has reviewed it, and here is another important point to be projected. I think it's very important.
Because maximum clinical data is from India only, and even when we visit FIGO conference and all, the maximum attendances are Indians only.
No, Sushma, let me tell you for this. The answer to that is our projections and our presentations and our analysis is extremely tardy. Our statistic, we are very, what should I say? We are wary of statistical analysis. So it has to start, we already have it in the curriculum, MBBS. Evidence-based practice has to be also included as a part to sensitize the students. And it is important for us to understand how to actually do simple descriptive analysis of studies. So what happens is when we communicate with the statistician, he gives you something else and then you ultimately end up speaking something else. So I think we also need to look at ourselves. That is one of the, but once you are robust and good in your thing, then there is no going back. So it is there.
There was one more point from my side. They have not mentioned the severity of FGR. They have taken FGR in the study.
FGR, exactly.
Yeah, but then they haven't mentioned.
Can I make one point here?
Yes,
yeah. So actually, when we are talking about this, the steroids, we have already accepted that these benefits are proven beyond doubt. Still, it has included in the study, and they have included FGR, as you have rightly pointed out. The severity is not graded. when we as obstetrician feel that it is a near-term baby and we are happy. But when we look at the pediatrician point of say, they say it is late preterm. And late preterm baby per se has its own complications. Neonatal morbidity, feeding difficulties, hypoglycemia, readmission to an ICU, late admission during the study, that also we have to, because hypoglycemia can be as a part and parcel of this late preterm, whatever aspect we are analyzing. So that is also one point, that you cannot, for a small single center randomized study, you cannot make a drastic comment that it doesn't help the respiratory aspect. On the other hand, it leads to hypoglycemia. Because I'm sure many of these clinicians, which are, thousands of these clinicians, including us, we have been using steroids over so many years now without any problems. Definitely, you have to follow the single dose schedule, no rescue dose, etc., as recommended by the IAP. But I think we really have to review this before coming to the conclusion of it. Thank you so much.
Thank you.
So, Dr. Shilpa, again, one thing that the severity of FGR is not mentioned, whether the Doppler is normal or abnormal.
One more thing I want to
because these can actually affect the neonatal outcome, especially the respiratory.
They have even taken SGA. SGA also they have taken.
All right.
So whether they are constitutionally small or really FGR, this also
that also should be. So I think it needs a lot of subgroup analysis in this study. Yes. So the numbers are small, they can take a larger number and do a subgroup analysis with stage 1, stage 2 FGRs. And because neonatal morbidity will depend on the severity of FGR.
Yes, ma'am. Depending on the etiology and
maybe
subgroups.
Dr. Shilpa can write a letter to them.
Okay, ma'am, with all your guidance, let me do that.
And also the mode of delivery. That also is not mentioned, or maybe I missed it when you were presenting. The mode of delivery.
Mode of delivery, what they've told us, that is the number of vaginal deliveries and the number of cesarean sections, they are also matched between the two groups. They said it's around 60% and 40%, 60% of C-sections and 40% of normal deliveries. That has also been matched between the two groups. That is what they've mentioned in that.
Yeah, but then the mode of delivery will affect the neonatal outcome as well.
Yes, ma'am.
I think a lot of subgroup analysis needs to be done on this.
Yes, ma'am.
I think in one of the limitations they have mentioned that they have not considered the severity of FGR.
Severity of FGR, and they've also mentioned there is no neonatal death. And one more thing is they're worried about the immediate hypoglycemic complications.
Yeah, have they written that?
Yes, yes.
Okay.
It's been uniformly noted that in most of them.
Neonatal hypoglycemia is one of the minor side effects that we see
only
after
that
antenatal steroids.
This is what I just
they say it is self-limiting.
That hypoglycemia is
Ma'am, your audio is not clear. Whoever is speaking. Hello?
Do you have any other expert comments on this?
I think I've, from my side, I think I've written.
Thank you, ma'am. Thank you for all the guidance.
Thank you, Dr. Shilpa. That was a nice presentation.
Thank you.
Very nicely presented, and also added the positive, negative on all the limitations, and good informations analysis of the journal. We'll move on to the next journal that will be presented. Can we have Dr. Asha CV, please? Poonam. So Dr. Asha MB is Assistant Professor, Department of Obs and Gynae, Mysore Medical College and Research Institute, and she's been very active member in the society and lecture coordinator and TOT for GDM and MDSR and all. And her field of interest is high risk obstetrics. Welcome, Dr. Asha, and she'll be presenting article from Journal of Clinical Medicine published in 2024. The topic is neonatal outcome following ECV, comparison between vaginal birth after successful ECV and elective C-section after unsuccessful ECV. Over to Dr. Asha.
Good evening, ma'am. Am I audible, ma'am?
Yeah, you're audible.
Good evening, ma'am. First of all, I would like to thank all the senior faculty of FOGSI and ICOG for giving me this opportunity to present this particular journal. 1 second, ma'am. I have a little problem with the screen share. Just a second. Just give me time.
Yeah, sure.
We'll adjust, madam.
You just need to alter the slide design, Dr.
Yes.
Asha.
Yes,
So
yes, madam. Sorry.
You can change the aspect ratio, no?
Yeah.
Yeah.
Yes, madam. I'm done with it.
Go to full screen mode.
Yeah, ma'am, I'm done. I think it is fine. I will continue with it.
Yeah, now it is visible.
Yes, madam. Thank you. This particular journal, that is the neonatal outcome following external cephalic version and comparison between vaginal birth after successful ECV and elective cesarean section after unsuccessful ECV. It was done by Flix and his et al. There were 4 other members along with it, and it was published in the Journal of Clinical Medicine in the year 2024, and I shall be presenting on it. And it's one of an interesting journal that I found, and I'll be discussing under the following outlines, that is the introduction, objectives, methodology, statistical analysis, results, discussion, and conclusion. Why this particular study was selected is one of the most important, though we are not doing ECV regularly day in and day out, but still why this topic we selected, I'll be explaining in these slides. That is the incidence of breech presentation quoted by them is 3 to 6%. And all of us know one of the most influential publication, that is Third Breach Trial, which was prematurely terminated because of the fallacies and the lacunate it had, and maybe one of the possible reason for increased rate of cesarean section amongst the breech presentation. Hence, because of this study, it has given a scope for many of the presentations and many of us to study what are the fallacies and what else can be done in the breech presentation. And if we can give a trial for vaginal, or we have to take for a planned section. This was one such study wherein the trial of vaginal delivery was tried in breech along with a comparison with planned elective section was done. And one of the important cause was there a subsequent drop in the vaginal breech birth after the term breech trial. And external cephalic version we have read in all our important books. It is one of an important manure that it is still but not being practiced day in and day out. So one such study which highlights us and makes us to move out of our routine schedule, that is external cephalic version, which can be tried, and it is non-invasive and the opportunity can enhance the chance of vaginal delivery from the cephalic presentation. And then next, the aim of this study was that vaginal birth after successful ECV is non-inferior compared to the elective cesarean section from breech presentation. To substantiate this, the author have compared these two, that is vaginal birth versus elective section and term breech presentation. For this, they have set an objective. They had 2 objectives, that primary objective and the secondary objective. The primary objective was to assess the postnatal outcome in terms of morbidity and mortality. The morbidity was analyzed in view of neonatal hospitalization, arterial and venous pH, and the Apgar score at 1, 5, and 10 minutes. And the secondary outcome was monitored as a success rate of ECV the rate of unplanned cesarean section, and the rate of assisted deliveries. Now, to attain these aims and objective, they set in a specific methodology. That is a study design. Again, it is one of the observational retrospective cohort study, which was one of its limitation. And the duration was 2011 to 2020, a long duration. And the study population was, in this long duration, they got 142 singleton pregnancy with non-cephalic presentation near term. And the particular study was done at Germany, then in the Department of Obstetrics, University Hospital for Women in Düsseldorf. And ECV was performed at 36 weeks gestation in para and 38 weeks in multiparous women. And the ECV procedure, how they did, they had described. The thing is, it's a daycare procedure, and expectant mother was given IV cannula, monitored CTG and ultrasound parameters, including umbilical and middle cerebral artery Doppler was also done. And an obstetric team was kept reserved in case of emergency, they had to intervene. And then, along with this, in the procedure, the patient was put in slight tenderloin procedure in position and to facilitate the fetal movements, and lubricant was applied over the abdomen to reduce the friction, as well as to monitor for monitoring of FHR using the ultrasound. And physician carefully manipulated the fetus by applying gentle pressure on abdomen and attempting a forward or a backward roll. Throughout the procedure, FHS was intermittently monitored using ultrasound to ensure the safety. And maximum of 3 attempts were given, only if the first and the second one was failed. What if the case was unsuccessful? What if, and in this case, the tocolytic was optionally used. Only in difficult cases it was used, and there was no use of anesthesia, and fetal well-being was also monitored 1 hour post-procedure. Along with that, ultrasound was also done by a sonologist to see if there was any placental hematoma and also check for the Doppler. And if no complication, the patient was discharged on the same day. And then the next question is, what if the procedure was unsuccessful? If the procedure was unsuccessful, an elective cesarean section was scheduled 7 to 10 days before the due date. And the procedure used was modified Miss-Gavladak technique as per the German guidelines. And along with that, the post-operative care, monitoring, pain management, and breastfeeding was also supported in it. And now, how was the data collected? The collection of the data. Data was collected based on, the data was collected based on these things. That is, the maternal factors and the fetal factors was analyzed. The age, the presentation the age, weight, size, BMI, gravida, para, placenta location, and if there is use of tocolytic, gestational age, and the mode of delivery. And in fetal factor, the presentation, sex, arterial and the venous pH, and the UPGAR, admission to NICU, weight components were analyzed. And this data was importantly put on the statistical analysis. We are all clinicians. We want only the results. And this data analysis, we'll leave it to our statistician. But in fact, in this journal club, I'd like to highlight that this statistical analysis is the most important aspect in any study. Without this, the validity of the study stands nowhere. So the there were descriptive statistical analysis as well as comparison for vaginal and cesarean section, like Z test, T test, and various tests were used for this, and statistical significance of less than P, that is 0.05, was quoted as important. Now the results. How was this result analyzed? The results were basically analyzed in 3 aspects. That is, structuring the study sample, describing the study sample, and comparing the outcome parameters. Now, structuring the study sample, I have given this. They have given this flow chart, but to understand this, we have to read through 2-3 pages. The thing, let me simplify. 1, non-cephalic presentation at term was taken, and they were broadly divided into ECV or no ECV. ECV, there were 142. This no ECV group in particular was just for an assumption. The basically study was conducted in this ECV group. And in this ECV group, again, it was divided into cephalic, following successful ECV and unsuccessful ECV. There was cephalic, that is 80 of them had cephalic presentation. That is half of them, more than half, that is 56%. And then breech was 43.7%. And this non-ECV, again, it was just for assumption that had kept, that is elective section, vaginal birth, and unplanned cesarean. section. In cephalic presentation, it was broadly divided into elective section, how many underwent vaginal? Elective section, there was no elective section. Whereas in vaginal delivery, non-breech, they had 62 vaginal deliveries. That is around 77.5%. In them, spontaneous delivered was 57 and Ventouse assisted was 5. And then in unplanned cesarean section, there were around 22%, that is 18. Similarly, in breech, they divided into 3, that is unplanned sections and vaginal delivery, vaginal birth. There were 12 vaginal birth even in breech presentation or unsuccessful ECV. And again, they were excluded from the study because it didn't meet the objective. And then elective section, there were 51. Hence, they compared between this vaginal of 62 and the elective cesarean section of 51 to come into the conclusion. And basically, an important assumption was made. What if direct cesarean was done without an ECV? For that purpose, they had assumed that the parameters of babies born by breech, either with successful or unsuccessful outcome was same. This is one of the assumptions that I had made. Basically, there was a comparison between these two groups, that is 62 and 50. What is this 77% and what is this 82%? It's basically the result that they analyzed. ECV, with the ECV, they had achieved a good birth rate around 77.5% with or without ECV. That is, if there were ECV, it's almost as high as 77%. And without ECV, in those whom they underwent elective cesarean section, the rate was around 82%. So it's an appreciable note that those with non-cephalic also landed up in vaginal delivery that is as high as 77%. And now, next, the success rate of ECV was 56.3%, that is 80. Amongst them, it was divided again, that is 77%. And in them, 91% were successful spontaneous delivery. And this particular chart, which looks very, very big, that is the maternal factors were analyzed: age, weight, height, and BMI. To simplify, height, weight, BMI were homogeneous in both the groups. Whereas age, there was a difference of 2 years because of the parity. And then the important parameters, that is the mode of delivery according to the parity. Multiparous had a successful vaginal delivery following the ECV, that is around 76% compared to nulliparous, only 36%. Hence, it can be taken that multiparous was significantly more likely to deliver vaginally compared to the nulliparous women. And this particular thing was also supported by odds ratio of 5.73 times. In this study, there were many tests and many results which looks complicated, but then just a note, that is, these are few of the fetal parameters that was considered. One is the length and the neonatal. The length and the neonatal HC was around 50 and 35 in both the group. Whereas vaginal born babies tend to be older by 1 week and heavier by 200 grams because they were left for spontaneous delivery. Whereas in cesarean, it was elective section which was planned 7 to 10 days prior to the due date. And then one more important chart which looks a bit complicated, but an important, a null hypothesis was proposed in this particular table, where was greater or equal difference to the median for neonates born vaginally was compared to an ES after unsuccessful ECV. The null hypothesis was proved wrong because of the significant V value. Hence, it was rejected and it was accepted that the newborns born with elective section deviated more than the vaginal birth. This particular thing I'll be explaining again in the UPGAR. Now, in both the results comparing the fetal outcome and both the samples, 2 neonates required NICU admission. The arterial pH was also analyzed. The arterial pH was much lower in vaginal birth compared to elective cesarean section and with a wide range of variation. Again, this is one point of debate, but it had a statistical significance. And then comparing the post-arterial pH. Again, the arterial pH was compared, wherein the standard deviation in I have simplified all these tables and put in this box. That is, the standard deviation in vaginal born was more compared to the elective section. Hence, the standard error of mean was all slightly higher in vaginal born, making this test and this study even more valid. Because of this validity, the results again can be told that the UPGAR was again used because of in the use of arterial pH. UPGAR is one of the important parameters that is most reliable and used. And the neonates that were compared in their UPGAR at 1 minute, 5 minutes, and 10 minutes, and the results were analyzed as follows. At 1 minute, at 1 minute UPGAR, the mean of most of the babies that born by either cesarean or vaginal, into is for elective section, and circle is for vaginal delivery. The mean was 9 and 10. But if you look at the graph, we can see that deviated more than the median. The vaginal, it was only 7 and then only 3 in vaginal group. And similarly, another comparison was also done at 5 minutes. At 5 minutes, again, it was analyzed. Still, the median remained 9 and 10. The median was 10, but there was deviation of the babies more in the elective section compared to the vaginal. So the UPGAR, the baby born vaginally, had a good UPGAR score compared to, and it was compared at 1 minute, at 10 minutes. The results were consistent again. The vaginal born babies were only 2, whereas the cesarean section, it was 5. So the deviation of UPGAR even at 10 minutes was higher in the children, in the fetus born by the elective section rather than the vaginal delivery. And the results were summarized. The summary of the results, both groups were similar, that is 3.2 and 3.9, and the mode of delivery was successful, that is almost 91% of vaginal delivery were spontaneous, and 8.1% required vacuum extraction, and unplanned section occurred in around 22% following successful ECV. And neonatal character, born babies had higher birth weight compared to the cesarean section, and the gestational age was higher in the vaginal group because they were left spontaneous rather than premature, rather than early termination. And an unsuccessful ACV, 43.7% of the cases had 43.7% of the cases had unsuccessful ECV. In them, the C-section rate was around 82%. But the vaginal delivery was also 17%, they were excluded. And coming to the discussion of the study demonstrates successful ECVs significantly reduced the rate of elective section in compared to the large database. And ECV trial alone reduces the expected elective cesarean section rate nearly by half. And the probability of unplanned cesarean following a successful ECV was around 22%. And the probability of vaginal delivery is also 77.5, that is around 78%. And multiparous had a better outcome compared to the nulliparous women. And then continuing with the discussion, there was a scientific evidence that neonate birth outcome after successful ECV is to an alternative cesarean section, and neonate born vaginally after ECV had significantly better UPGAR outcome compared to those born via elective cesarean section. This was consistent with the finding and with the Cochrane finding of 2015 analysis. And the arterial blood pH in the vaginal born babies would likely the physiological stress they had, and the ongoing this is one of the topic of an ongoing debate, and hence the authors have also considered UPGAR as the most parameters, and for the multiparous women in particular, ECV presented a favorable option to reduce the risk of elective cesarean section while managing the positive neonatal outcome. And with all these things, all the study always have some or the other limitation. So does this study. One of the limitation is the small sample size and the retrospective design, which may affect the generalizability of the results. And for the prospective study, and this study particularly gives a scope for a prospective study to need the validation of the finding, address the parity-specific outcome more comprehensively, and to conclude, neonatal outcome from vaginal birth after successful ECV are comparable to those of elective section. High success rate of ECV and favorable outcome, especially in multiparous women. ECV should be viable option. A healthcare provider to be encouraged to offer ECV to eligible pregnant women to potentially reduce the need for cesarean section, and the procedure has proven to reduce C-section rate. And with this, I like to put an important quote by Albert Einstein, that is, Sir had quoted, if we knew what it was we were doing, it would not be called research, would it? I think most of us would accept with this. And with this, I'd like to conclude. Thank you, one and all, for the patient hearing. And I'd like to thank Madam and Radhika Madam and Kavita Ma'am and Sneha Ma'am, Charmila Ma'am, and all the faculty of FOGSI and ICOG for giving this wonderful opportunity to present. Thanks a lot, Ma'am. Over to you, Ma'am.
Over to the experts.
Thank you, Dr. Asha. Thank you so much. One thing I want to ask you, have they mentioned anything about the cases that they did not take for version?
Yes, madam, they had included 152 cases.
No, agreed, but which they did not include, and why? What was their finding?
No, madam, they have just given in the article that they had included 152 cases initially, but then...
So I think, they need to mention...
142.
They need to mention very clearly what were the contraindications where you should not do. If you have a paper that is promoting version and you're not writing what are the contraindications, then, I think all the results are a sort of, biased.
No, madam, they have given one thing, that all the contraindicated as per German guidelines were excluded from the study. But what was there, it is not specifically included, but they have mentioned a line saying that as it is done as per the German guidelines. That is mentioned, the contraindication in the German guidelines.
No, Dr. Asha, I did not find any contraindications written in the journal.
Yes, madam.
One of my questions was same thing. They did not write the exclusion criteria for ECV.
Yes, madam. They
have not written. Yeah.
Yes.
And even in the article, in those who failed external cephalic version and then they had normal delivery, they have not mentioned whether they have a breach or vertex when they delivered, because they have no data. So,
they have
the way it is presented, it sort of looks that, a vaginal, it will deliver normally vaginally. But that is not a fact, because they have clearly written, they don't know the mode of presentation in those cases. And that is why they have excluded.
Yes, madam. I agree with you, ma'am. Yeah, yes, madam. Correctly pointed
out. It is being a retrospective study. How judiciously they would have categorized into the selection will happen properly in a retrospective data, and making it to two different groups which have already existed, that will not be justifiable.
More so, ma'am, if we notice, it's a case of study of 142 cases over a period of 9 years.
Yes.
That is 2011 to 2020 they have studied, and just 142 cases. So I don't think it's a robust data for external cephalic version. It clearly signifies that not even, not even 2 cases per month were there in which ECV was tried.
Can I, Asha, with your permission, Asha, Radhika, one thing. Actually, every expert is something in this paper. Am I audible?
Yes, madam.
So the inclusion criteria, exclusion criteria, besides it's the ethical issues, because many patients, if we explain risk and other thing, whether they refuse, so that should be the part of paper, that how many patients they refuse the ECV, and what was it, and secondly, any complication they find. So that makes us something realistic. It is just conducting like something that it will result into the very high incidence of vaginal delivery. So clear inclusion exclusion criteria, and why the in few patient and the recurrent, like it is not, it is a recurrent but like turn to the breach or the malpresentation is very common. So that will really add something realistic, like something to the clinician that they can opt in their practice or not. Your opinions, just few.
Also, ma'am, they haven't mentioned in the methodology that a consent was taken before external cephalic version, whether complications were explained. Because I think the methodology, you have to really write the details before going on to this thing. But so I understand it is a retrospective study, but I think they should have mentioned that the consent was taken before ECV was done. And they have also written, Dr. Asha, that if unsuccessful, a second attempt was considered. So
Yes,
when was this a second attempt considered?
I think they have not mentioned that in this methodology is not
They've
explained.
also written tocolytic agents for optional. Again, we have to be very specific when writing tocolytic, what tocolytic was given. And then they have conducted 1 hour CTG after the procedure. So were there any CTG abnormalities?
No, if it, they
I
would
understand the maternal outcomes were not taken into account, but when you are talking about the result that ECV should be promoted, I think maternal side also has to be looked into.
That's what they have given. One thing they have highlighted is for those who opt for vaginal delivery, those who see vaginal delivery, it can be an option. It can be kept as an option. That's it. It is not that we have to do. It is just a viable option. Yes, madam.
And
they have mentioned, if I am not wrong, in the paper that a trial of ECV resulted in a vaginal birth in more than 50%, and they have mentioned on 142 of cases, and with 85%, that is 62 out of 73 of these were from known cephalic. So what we were discussing, they have not mentioned how many were cephalic when they delivered. So that point they have definitely mentioned. And additionally, and they have also mentioned that out of 142, 51 underwent a planned cesarean section due to unsuccessful version.
That is
So
because of the
this part
persistent breach. Yes, ma'am. That they have explained that if
they
the
have
breach
explained.
persistent, that I had put was little complicated. That's what they have tried to explain. If it was persistent, then directly they were taken off a cesarean section. If those whose presentation at the time of delivery, whether cephalic or breech, was not known, then they have excluded. That's what is the 11 members that they have excluded. Those who were delivered by cephalic presentation were 80. In them,
I think it would,
whether it was spontaneous or it was a planned section, or whether was it assisted like Ventus assisted.
yes. Yes, I think they could have been little better if they had mentioned that there were total number, this much number of breach over a period of 9 years, and out of this only this much agreed for external cephalic version, and out of that then at least it could have been something realistic, because
but they concentrated more than
They
the
should
clinical
also
aspect.
project the institutional data of annual and monthly delivery so as to have a the genuinity of the procedure they are doing. So it's almost looks like they had a pre assumption of the result they wanted.
Whatever, but then Dr. Asha has very beautifully presented. They might not have done justice to the subject, but Dr. Asha has definitely done very much justice to the presentation, and it was really, really great.
Dr. Asha, I wanted to ask your interpretation. I have the study in front of me.
Yes,
Table
madam.
3, where they have described the proportion of vaginal birth and emergency cesarean, elective cesarean, sorry, after unsuccessful. So why do you think the nulliparous women had a higher chance of having vaginal birth after ECG?
Multiparous had a higher vaginal birth compared
why?
of the parity. First, the parity.
Okay, but what about parity?
Easy for and if at all they have already had a vaginal delivery earlier, probably they want it And probably this.
No, but why they had more of vaginal deliveries as compared to nulliparous? What is your interpretation?
Otherwise, no, compared to the primary, the second pregnancy is always safe. So probably parity, the lax abdomen, which favored the
If you do ACV, yeah, because it is easier in a multiparous lady because of the lax abdomen. Am I audible? Yeah, so that is why I think because of the unsuccessful ECV, which was higher in nulliparous, so less vaginal deliveries.
Yes, madam. Probably yes. It could be one of the possibility.
What is the Z-score proportion? Can you help us understand?
Z score and all, I am not the better person, but as much as I know.
But in your opening statement, you said clinicians don't take up statistics.
I'm more concentrating on the clinical value and we'll but then the Z-score help us to analyze whether the comparison between the two groups. So it is actually
it is a comparison between two means.
Yes, madam. It is yes.
And the standard deviation between the two groups.
That's what they
estimate.
Compare in the vaginal versus the.
So that is what they have done. ABGA score, the mean ABGA score, they have compared with this Z scoring.
Yes, madam.
And it is quite surprising that in pH, the pH was less in vaginal, but the ABGA scores were higher in vaginal.
That is one of the points that even the authors have highlighted, and they have also in discussion validation, and that's why they have taken the ABGA more valid over the pH. And because there were contraindication whether the pH has to be taken or an ABGAR has to be taken, but they safely took the ABGAR, and the reason they should quote.
Yeah.
Yes, madam.
But I think the baby undergoes through stress during vaginal delivery, and hence the
that particular thing. Yes, they have the study as well. This physiological as such labor is a stressful process, and it does have an impact on the arterial pH compared to the ES.
So it was a nice study, and I think you have made a good choice of presenting this.
Thank you, ma'am. And always
nice presentation also.
Thank you, ma'am. Always, it's like because of the rising trend of cesarean section is still and the lost of the few things in the modern obstetric era, lost art. It's one of the last art that I can tell. Because most of us don't practice. Though we read in a research topic, we need to do something that we are not practicing day in and day out. So because of that, I thought we'll put a light into it.
Yeah.
That's why we selected.
ECV is also a dying art.
Yes, madam. It's one of the dying art, like forceps.
Yeah.
And ventouse.
Thank you.
Thank you, madam. Thanks a lot.
Do we have any more inputs from the experts? Okay. We should really congratulate both the presenters, Asha and Dr. Shilpa, for putting across the two articles in a good way. And it rose up a lot many queries in the journal literature presentations and the research methodology and how we should approach. And of course, this platform has given a good input more to our postgraduates. Hopefully, we appreciate for the postgraduates who have logged in and taken the feedback of the way and the art of the presenting and analyzing the journals. And it should be a good light for the young learners especially. And sincere thanks to all the experts for taking their precious time and giving their active inputs to the literature. I sincerely thank all the members who are part of this. And personally, I thank Dr. Chamila ma'am and the team of FOGSI, ICOG and JOGI for giving this opportunity and being part of this exuberant research methodology of ICOG and JOGI. Thank you everyone for being part of this extravaganza knowledge. We hope to come back with many more research articles and to enlighten us. Thanks everyone for joining us and making it a successful event.
Thank you, madam. Thanks once again.
So I think I can call it a day. Thank you very much, everybody, for joining in. I think Mysore Medical College really performed exceedingly well with all the interactions. Many thanks to the experts for being there and making this so interactive.
At this platform, we are proud to say that we have conducted the FOGSI South Zone Conference we hosted from Mysore. And it was a great successful conference and very well appreciated by the whole nationwide faculty, and Dr. Shamila and Jaideep Tank were the part of it, and I was the organizing secretary, and both my colleagues were also the part of the organizing team. It was indeed a proud moment for Mysore to organize this South Zone.
Great. That's great to hear that. So thank you very much. So I think we would like to thank the audience for also listening through all this. I think now we have dwindled to 21, but there was a time when a lot of people were actually listening in. So that also shows the popularity of this program. So thank you very much. Thank you for Imagika for being there, and Poonam from ICOG for coordinating the entire effort. So, and thanks to you, Sushma. Thanks for coordinating the event. Thank you, Dr. Kavita, for
thank you, Dr. Adhika and Dr. Sushma. I really enjoyed the discussions.
Yeah.
Thank you so much, ma'am.
So did we. Thank you.
Right.
Thank you so much. Thank you, Asha.
It's always a pleasure to be part. Thank you.
Bye. Bye.
Bye bye. I think we'll wind up.
So much, ma'am. So from here, I'm ending this meeting.